Okay, welcome to HRT or Not month. I'm chatting with Victoria Howell. Do you want to tell us a bit about what you do, and then we'll get on to the magic topic?
Yeah, thanks, Emily. So I'm a menopause nurse, so I see women in my clinic on a one-to-one basis to give them support to enable them to have an informed conversation with their GP. And I also do training in the workplace, so general awareness training for managers and champion training, and a lot of speaker events. And I also do a staff menopause clinic currently for Kingston and Hounslow NHS Foundation Trust. So that's what I do in a nutshell.
Awesome. So, HRT. Now, I'm going to start at the very beginning. A lot of people are quite wary of it, aren't they? Because of a study that happened in 2002. So let's just get that out of the way, shall we? And then we'll
Yeah.
get on to the ins and outs of it now.
Yeah, absolutely. So it was a big piece of research, which overnight a lot of GPs stopped prescribing, and a lot of women stopped taking them because it was in all the tabloids. You get breast cancer if you have HRT, it's bad. So all this was going on, and if we see something like that, we are going to be scared. Um, and since then, it's been uncovered that that actual evidence research, the evidence of that was actually flawed. Okay. It was done on people over the age of 65, and a lot of those people had, in my understanding, had breast cancer previously. So since then, there's been a lot of change. The NICE guidelines, NG23, that we have now, which is currently they're revising, and the new NICE guidelines will come out 12th of February 2024. And the whole purpose of the NICE guidelines, they inform both clinicians, but lay people, we can have a look on there as well to find out more. There's a summary rather than having to read the whole document. And yeah, NICE recommend HRT as the first line treatment for menopause symptoms and obviously perimenopause symptoms. And the HRT these days is very, very different, which is now body identical, or most of it is body identical. So it's the closest to what our body makes itself, and the side effects are far less. Now, if anyone is concerned about breast cancer, the British Menopause Society have a really good infographic on the risks of breast cancer, on a piece of research that the British Menopause Society and NICE did back in 2015. And it was on a group of 1,000 women in the general public. Out of that general 1,000, there were 23 cases of breast cancer. With women who are on either the combined contraceptive pill or combined HRT, there were 4 extra cases. Now, I can't remember each fact, but there were a few extra cases on those who had over 14 units of alcohol a week. There were a few extra cases with smokers. I think there was 3 extra cases with smokers.
Yep, there's a few
Women,
extra cases for people who were inactive, and there were a few extra cases for people over a certain BMI as well. And then
absolutely,
there were quite a lot less cases for people who were very active.
absolutely. So the biggest risk was those with a BMI of 30 or more. However, so there were 24 extra cases. As you rightly say, those who were active for 2.5 hours a week or more, there were 7 less cases. Okay. Women who no longer have a uterus and don't need progesterone, so estrogen only, there were, I think it was 4 or 7 less
That was a
cases. But
reduction. Yeah,
yeah, absolute reduction. So all medication has side effects and risks, but it is very much lifestyle factors are a huge thing. So, and when they say exercise, you don't have to be running marathons, you don't have to be doing crazy, high intensity, even a good brisk walk, anything that helps you. And things like yoga, they
yeah.
really help. And they help not just the body, but they help the mind as well. So
Which
it
is
just helps you feel calmer, which is which is really good. So yeah, there are risks, like there are with any medication, but there's the benefits as well.
Absolutely. So let's say we're talking about somebody who has her uterus. What would she be needing in terms of HRT?
Okay, so current guidance um, by NICE and the British Menopause Society and the Faculty of Sexual and Reproductive Health. Though she has a choice, so there's always choice. So if somebody starts a particular regime and they're giving it a go for a couple, 3 months, and it doesn't feel right, or they haven't experienced any improvement, there are different regimes and different doses. Okay, so a woman who still has a uterus intact, she would, and if she's still having periods, she would need what we call a sequential regime. So what I mean by that, so the first 2 weeks, estrogen only. The second 2 weeks, estrogen and progesterone. So that is mimicking our cycle. Okay, so to keep that regular. Somebody who no longer has periods, she would need a continuous combined preparation. So that's your estrogen and your progesterone daily. And the reason for that, I get my lovely model here. The reason for that is the estrogen makes our uterine lining nice and thick and moist, ready for a sperm to impregnate us and, hold a fetus. Now, if all we did as post or perimenopause, I have to stand up here, Emily, forgive me. If all we did was have estrogen, the lining would get thicker and thicker and thicker and thicker, which we don't want it to do, because that leads to something called hyperplasia, which can cause, pain and problems, but also, if undetected, can lead on to endometrial cancer. And decades and decades and decades ago, when they started HRT, that's what they found, because they only gave estrogen. Okay, I'm not talking about 2002, I'm talking way back. So that's when they realized, oh, actually, this is causing a problem. So the reason we need progesterone is for our endometrial protection.
And
Would
then,
you like me to?
so
Sorry.
let's go through. Let's start with the progesterone. What forms can we get the progesterone in?
Okay. Progesterone is in a variety of forms. One form is, I just looked up and I saw this, is the Mirena.
Okay.
It's a bit like Marmite. People either love it or hate it. Some people have had the Mirena inserted. This is what it looks like. And they find that they're too sensitive to it and they want it taken out. So you can see it's a small little thing,
Yeah.
and it's very pliable when they pop it in. Now, some women have had the Mirena and they've had 3 or 4 inserted because they love it. Okay. It's a contraception. It's really good for any women having heavy menstrual bleeding. So if they're perimenopausal and they're having frequent heavy menstrual bleeding and they've had a hysteroscopy and nothing is showing up as that needs treating, this can really help because it's got progesterone in it. So it's feeding that endometrium all the time, keeping that nice and thin. So that's one form. Another form is something, and this is the body identical form. It is called Utrogestin, and that is body identical, and it's made mostly from wild yam and soya. Now, they do recommend if an individual has a peanut allergy, they perhaps may not have that because the soya in it can have the same effect of nuts. So that's something to be aware of. Now, the benefits of Utrogestin, we take it at night. And the reason we take it at night is it helps us sleep better. It helps most women sleep better. So we wouldn't take it if I'd have taken mine in the morning, I'd have been sitting here like, hi, Emily, how you doing? And we don't want that. So it can really help people sleep better at night. And as we know, difficulty sleeping and waking at night is, a very common symptom of peri and postmenopause. So there's that way. Other forms, you can have it in a patch. You can have a combined patch, which has your estrogen and your progesterone in. With the patch, you simply stick it on the side of your thigh and you change it twice a week. So you've got that consistent dose of estrogen and progesterone. And you can also, so you can get that in Conti, so daily, of both estrogen and progesterone, or you can get it sequential. So the first 2 weeks of estrogen and the second 2 weeks have your estrogen and progesterone contained in it. So you don't need anything else other than that. And yes, there are other tablets, but they're the most common ones, and there are progesterone tablets. And I know when Eutogestin was in short supply recently, some GPs were having to prescribe different forms, but for anyone prescribing, that is available on the British Menopause Society website. So if they're not sure, they can just look and then they can advise women that way.
So moving on to the estrogen, how can we take that?
Okay, so estrogen, and again, you can have tablet, you can have an estrogen tablet, you can have a combined estrogen and progesterone tablet. We do not recommend anyone who has had a DVT or pulmonary embolism and those sort of risks of stroke and thrombosis, because there is a slight increased risk of that. People who are not at that risk mostly prefer to take estrogen transdermally, so they're not subjected to that slight increased risk. Okay, so transdermal, either a patch, again we change that twice weekly, so you have that consistent dose feeding through. There is the oral, and sometimes it's the oral is the only one that works for women, helps them with symptom control, but that would be with a conversation with their GP. We have the gel. There's various gels. This is probably the most common one, which is estrogel. There's Sandrina and a variety of other gels, and you literally pump it out. Okay, this is purely a placebo. Now, you can see it's quite a bit there, and the instructions for that says you can pop it on your arms. The only thing is you need to smear it over and allow it to dry. Okay, so if you've got your arms full of that and you're popping your makeup on or doing your hair or getting your breakfast, you do run the risk of them getting near your breasts, and that's my concern. That's purely my concern, because we don't want estrogen near the breast. Okay, so I recommend that we put it on the thighs. One, there's so much gel in one pump, and if you're having 2 or more pumps, you need a bigger surface area to smear that gel. The other thing, you need to apply this daily, because at the end of the 24 hours, it's stopped doing its thing. Okay, so, and you need it on for a few hours before having a wash, a shower, or going swimming or anything like that. So for some people, if they are very active and swimming, they might find a patch easier. There is another transdermal, which is relatively new. It's been out a couple of years, 2-3 years, and that's a Lenzetto spray. And I don't have one of them to play with at the moment, but say this is a pump, you pop it sort of like on your wrist and you squirt it, and you need to allow it to dry. That is in use, but I don't know anyone who is on that myself at the moment. And I know that the gel is very popular. Some people, the patches are amazing and they stick on. Other people find that they don't stick on. And like I say, whatever one chooses, they can always go back and get it changed if a particular route isn't working for them.
And I think that's worth just quickly elaborating on, that there's this kind of perception that HRT is just one thing, just delivered in different forms, but actually, like painkillers, like antibiotics, they're all slightly different, and different people are going to get on better with different ones. So if you find that the first one you try isn't right for you, whether because of a lifestyle thing that you're not having time for the gel to dry, or because it's not affecting your symptoms, that's not a reason to think that HRT just doesn't work, is it?
You're spot on. You're absolutely right, Emily. It has to be very individualized, you know. So this is why, yeah, look on the Women's Health Concern website at their HRT guides and the information on that, which, Emily, you're going to pop the link in,
Yeah.
aren't you, at the end of today? It has to be individualized because, you know, what if we're having the same symptoms, our perceptions of that are going to be very different, okay? And it's going to, you know, two different people, one, it's going to suit them really well, the other, oh, I haven't really noticed any difference, or actually I've noticed these side effects that I'm not happy with. So yeah, do go back, talk to your health clinician at your surgery who knows most about menopause, and have that conversation. Look, this isn't working for me. What else can we do? Because there are other things. And like you say, HRT isn't the wonder thing. Okay. Some people start taking it and they feel amazing. Yeah, some people were going to try trial and error, try different things. And yes, it may alleviate some things, but we may need a different dose. We may need a different route for it to fix us. But it has to be in line with lifestyle factors. So your
Absolutely.
hydration, your nutrition, exercise, self-care. And self-care includes being kind to yourself and not putting yourself under pressure to do all these different things at once, because, you know, we need to be kind to ourselves as we would a friend or someone in the hub. You know, there's so much kindness there, and that's what we need to be. We need to practice how to be kind to ourselves. So yeah, it has to be that holistic view.
So I'm going to ask one quick question off the back of that, and then I'm going to cover off one little other topic, and then we'll call it a day, because I know people's concentration levels in perimenopause are very short, so we don't want to inundate them with information. In your opinion, both as a nurse but also as an individual human being, do you think that HRT is a kind of an important part of the toolkit to managing menopause?
Yeah, it can be. It can be. It has to be an individual's choice. If an individual doesn't want to know about HRT or anything like that, they need to be respected. It's their body, it's their choice. Yes, HRT can help with symptom control, but we know the NICE and the British Menopause Society tell us that it gives protective benefits to bone and heart. There is more evidence emerging that it helps with brain, like things like dementia as well. Okay, that's due to the fact that we have estrogen everywhere in the body. So it can help reduce the risk of osteoporosis, reduce the risk of cardiovascular disease and type 2 diabetes, in line with those healthy lifestyle factors. HRT alone isn't going to do that. And it can take, you know, they say to give it 3 months. It can take longer than 3 months, but by tracking symptoms, you would notice a reduction. I would hope you'd notice a reduction in symptoms. Yeah, does that answer?
It does. It does.
Yeah,
Absolutely.
good.
So my one last question, because I know you want to use your pelvic floor thing
Yeah,
again, I just want to talk about localized estrogen for vaginal dryness and vaginal acne.
absolutely, absolutely. So we nowadays we call it genitourinary
I know.
syndrome menopause, GSM, because they now know that it doesn't just affect the vagina, it affects the bladder as well. So we may find that we're getting up in the night to do a wee a couple of times. We may notice that if we sneeze, we have to cross our legs so a bit of wee doesn't come out. We have estrogen receptors here in the trigone area of the bladder. So that helps, in line with pelvic floor exercises, that helps the urethral sphincter. It opens when we go for a wee, it closes when we finish. When we have insufficient levels of estrogen, I liken it to a bit like a door fluttering in the breeze. So if we sneeze, it goes like that, hence a bit of wee comes out. We need estrogen for the mucosa of our vagina, okay? And we also need it for the vulva. when we have insufficient levels of estrogen, the vagina, instead of being nice and plump, a bit like the inside of our mouth, it gets thin and dry, so it can rub, the walls can rub against each other. The vulva itself can look pale. Instead of that nice dark pink colour, it can become pale, and the labia majora and the labia minora can start to fuse. The other thing that happens is the opening to the vagina shortens and shrinks. Okay, so having a smear test can be really uncomfortable, and even penetration can be uncomfortable. So with the addition of local estrogen, now that is in the form of a pessary. Some people prefer the pessary, so you can see how big it is compared to my finger. There is also a Vestin, which is a cream, and you literally screw it on, and you can see that orange line. Well, it will only pull back as far as that orange line, so that's your dose, okay? And you literally pop it into the vagina last thing at night before going to bed for 2 to 3 weeks initially. Following that, you use it 2 to 3 nights a week as a maintenance dose. So when you check your vulva, if it has started to get pale and fused, and you're noticing those other symptoms like dry vagina, as you mentioned, after a few weeks of using local estrogen, it replenishes that area to its former glory. So it is very, very effective. And the dose of hormone in here is super, super low. I think it's around about a year's supply is equivalent to one HRT tablet. So it is super, super tiny. Obviously, there's different lubrications they can use as well.
And I just want to say, if anyone's worried about the localized estrogen, because I think a lot of people think if they're contraindicated for having estrogen otherwise, that they can't have the localized one, which is a conversation to have with your doctor. But I'm not aware of people being contraindicated for the local estrogen. This book is really worth a read if you want to understand what's going on and why it can help. It sort of makes it sound like I'm on a bit of a mission to get everybody to have localized estrogen. I'm not at all, but I think it's a part of the jigsaw that we often overlook, and you know, I hear this from people all the time going, oh, it just hurts down there and it's itchy and I'm just uncomfortable and I'm getting recurrent UTIs and all these things that I think people don't realize there's quite such a simple solution to.
Absolutely, absolutely. And if they are contraindicated, there are non-hormonal moisturizers, vaginal moisturizers. There's Yes, as you know, there's Silk, there's Balance Active. They come in little pessaries that you can get from pharmacies. So some people use coconut oil. So there are non-hormonal alternatives as well if they are contraindicated.
And yeah, and I think the most important thing there is please don't suffer in silence. We need to, there is
Absolutely.
help.
Yeah, absolutely. There is always help. Don't think that it's just you going through a particular thing, because there's
Yeah.
always hundreds of other women going through exactly what you're going through as well.
Yeah. Awesome. Thank you so much, Victoria.
You're welcome.